Good afternoon, good evening. Thank you so much for joining us for the Mpox and Marburg special briefing from AfricaCDC. My name is Margaret Edwin, the Director of Communications. I will be moderating this session. We are joined today by the Honorable Minister of Health from Rwanda, Dr. Sabin Nsanzimana, and the main speaker will be the Director General of AfricaCDC, Dr. Kaseya, who will now open the session with his opening remarks. Over to you, DG.
Good morning, good afternoon, good evening to all of you. Welcome to our weekly press conference. We are joined by Honorable Minister of Health from Rwanda. And we thank him because at the same time he's chairing the board meeting of Pandemic Fund, that he decided to be with us for 15 minutes. Then I will hand over to him for the presentation of the situation in Rwanda and also questions. Then we can continue with Mpox. Over to you, Honorable Minister.
Thank you, Director General Jean Kaseya, for having me again for the third time, if not the fourth time, on this platform. So thank you also for visiting and the team on ground. So I would like to start by saying that the Marburg response in Rwanda has improved. We're seeing positive trend comparing weeks. This is the third week, and the new infections from Marburg have reduced by more than 50%. Compared with the first 2 weeks. So we've had consecutive days this week without any new infection detected. And we've also seen the case management improving. And we had consecutive days with zero mortality, zero case of death, which is also encouraging. And third, we've seen also the past 7 days, most people recovering from treatment centers, outnumbering the people who passed away from this virus. And we've seen also more vaccinations happening, especially the close contacts of confirmed cases, known as ring vaccination. And we've also seen positive trend in use of new therapeutics that have contributed to these outcomes. So the latest numbers are that cumulatively we've confirmed 62 cases of Marburg virus in Rwanda. We have recorded 38 recoveries. We have recorded 15 deaths, and we still have 9 cases who are under treatment, of which most of them are, majority are improving. And the case fatality rate overall is 24%. So we've vaccinated 856 people since we started. We had initially received 700 doses we talked about last week. And all those doses we received have been used. And we're also happy to have a second shipment of 1,000 doses that we started using a few days ago. So we anticipate to continue vaccinate those at high risk and those close contacts, but also healthcare workers at frontline most exposed, and other we see that could be potentially infected. So we are conducting massive testing. So far I've done more than 4,000 tests, and we still do on average 200 to 300 tests per day to make sure we don't miss any case presenting symptoms suggestive to Marburg virus disease. So overall, the trend is very encouraging, very positive, both on the new infections declining significantly, and also the mortality reducing in a trend that I would say is very encouraging for people on the front line. So as we said before, majority of people affected are healthcare workers. They are the front line, the ICU cluster we talked about. They remain the most affected, and their contacts. More than 85%, close to 90% are healthcare workers, healthcare professionals we are talking about among these cases. So we've made also progress in other sequencing activities that we've had support from different partners, mainly AfricaCDC, working together with Rwanda Biomedical Center scientists. We may be issuing the report and also putting the findings to the public and scientific community use in the coming few days. So the team has finalized everything. It's just a matter of putting all the information together, and this is coming in a few days. So I expect this as the next highlight of this Marburg response in Rwanda. On the other hand, we have a very active team working on One Health, trying to trace the root of this infection. That also is coming soon. We are planning also to provide these two updates in a few coming days. So we are intensifying contact tracing, although the cases have declined significantly. The last 3 days, 4 days, we had no case, and the testing and the searching had increased significantly. We believe that this ring vaccination has played a big role, and also we believe that the intensive work being done on ground is also helping to capture all the cases and their contacts. Finally, on the travels on the borders, we continue to intensify screening for people departing from Rwanda at the airport, international airport in Kigali, but also other land borders and water borders. So we have been consistent to make sure that we protect everyone in Rwanda and beyond, because this virus has to be contained quickly, and we don't want this to go out of our control. And that's why we really appreciate our partners. And AfricaCDC, we've had WHO coming in, we've had US CDC, we've had European EU CDC. The Director General called me this morning because we aligned in different fronts to make sure that we all finish this problem and we learn from it and we get ready for other similar outbreaks. So briefly, I was just to share this good news that the trend is positive and that we're going to hopefully soon, or as soon as possible, to have 0 cases for several days and 0 death for several days, but also continuing to see how we raise our alert and how we don't drop our weapons, because this is an alert that what happened in Rwanda on Marburg can happen anywhere, anytime in the world. So the more we work together, the more we share this information, the better we are all prepared as a continent, but also as the humanity, as the world in general. So I pause here. As Dr. Kaseya said, I have only few minutes, I want to join you so that I can also join my colleagues at the Pandemic Fund Board, also discussing the same topic. Thank you.
We thank Honorable Minister for this presentation. Good news that is sharing with us. Margaret, let me hand over to you for questions from journalists to the Minister, because he has to attend the Pandemic Fund Board meeting.
Thank you, DG. Thank you, Honorable Minister. We'll take one question from the floor. Paul from the Lancet, you have the floor.
Yes, thank you very much, Honorable Minister, for the update. My question has to go focused on health workers. We have this high proportion of cases among health workers, and I think tying it to one of the public health mandates of the AfricaCDC, which is to improve the skills of health workers in Africa. So which approach are we taking to improve the skills of health workers, not just in protecting themselves, but in order to better respond to these outbreaks? I know during the early days of the COVID-19 pandemic, we had regular online trainings organized by AfricaCDC. Now, stemming from the experience of virtual training to what we currently have, so what is the strategy towards improving the skills of health workers, not just to be able to protect themselves, but to be able to respond to these outbreaks? And is this something that can be exclusively done online, as we did in COVID pandemic? Thank you.
Thank you. Over to you, Honorable Minister.
I thought the question is for Director General AfricaCDC, but let me speak also on the side of member state, the country, where we think that the best investment any country can do is to make sure we have the people trained, especially in the health workforce, well trained in all specialties, well retained, and well protected as they work in a very specialized environment that can be also risky, as we're presenting on this case virus showing up. So I think two things. One is continuing to train, especially these areas where we have very few specialized people, for example, in ICU, emergency and critical care. Secondly, is to ensure that these areas are safe. IPC is very important, and it's not the infection prevention control about just cleaning. It's about infrastructure, is about the infections, knowing exactly the pathogens. It's all about surveillance, and is also waste management, is also how we build and equip these facilities in a way that they are safe for patients and also for the health workers. Beyond that is social support, moral support, conducive environment, So these are key things we are working on our extended plan, response plan, at least at country level. So thank you, Paul.
Thank you very much. Let's take the next one question before the minister leaves. Priyanka from New York Times, you have the floor.
Hi, I'm from Chemical and Engineering News. This question is for the Minister, Dr. Sabin. I was just wondering, how many doses of the monoclonal antibodies do you have, and is it enough for people?
Thank you. Thank you, Priyanka. So far, we've received in total 10 doses. These are the individual doses for monoclonal antibodies. They are not enough, but they are useful.
Thank you very much. Sarah Javing from DVEX, you have the floor.
Honorable Minister, can you talk about how the outbreak response has evolved in Rwanda in recent years? Do you think lessons learned from the pandemic has played into this successful response and kind of systematic changes that have been made in the country in the last few years? Thank you.
Thank you, Sarah. The outbreak detection and response in my country has evolved. We've been exposed to different types of outbreaks, and including COVID-19, like anywhere in the world. But we live in a region of the world where most of outbreaks are happening, especially in neighboring countries. That has been, for us, an area of investing in our preparedness, in our systems from community level to the top level of care. One, the outbreak response globally needs to be adapted and adjusted. It's no longer about the traditional surveillance from community only. We need to strengthen hospital-based surveillance of pathogens, especially these teaching hospitals where most of patients end up with very high risk, also explaining different types of pathogens. Second is the power of using latest scientific tools and quickly working with different partners without bureaucracies and being fast enough to activate the response written in books and make sure they're operationalized on the ground. So we're still learning, but the lessons we learned from COVID-19, from Mpox, from previous outbreaks, we have outbreaks alerts in the region almost every day. And that has helped us to strengthen also our detection and response. I'm sure at the end of Marburg will leave us with many more lessons for us and for others. I thank you.
Thank you very much. We have one last question, Honorable Minister, before you go. The question is from the chat box. The cases disaggregated by mode of transmission, that's zoonotic and human to human. How is the vaccine acceptance, and is it administered to health workers only or to the general population?
Thank you. So far, the cases, 62 cases we've reported, were from human to human transmission for people we tested, and these are close contacts within the hospital clusters. We are yet to determine the link with the One Health zoonotic origin or not. This is part of the final testing we are doing, including serology and sequencing, for which we are about to finish. So we're going to be updating on this progress. Second, the question on vaccines. The vaccines we are providing are highly accepted, especially among healthcare providers. They are at frontline, they're exposed, they have read about this vaccine, and there was no issue of hesitancy whatsoever, at least at the level we are today. Indeed, the demand is much higher, but we had limited doses, and this, as you know, is an investigational vaccine, and the speed of delivery is different because it has to go different procedures, consent, documentation, samples that is different from usual vaccines that are provided. So we are aiming to vaccinate more of those exposed, close contacts, but it's not a vaccine we plan to roll out massively to the rest of the community or the populations. It will depend on the current protocol in use, which is also evolving with our partners from US Sabin Vaccine Institute, in particularly the WHO, which had initially, we've worked on a protocol before, and we may be merging or transitioning on both to the one we had initially, which had some delayed arm, as we discussed in a previous briefing. I thank you very much.
Thank you, Honorable Minister. We thank the Minister. Let us conclude the Minister by the good news that for the past 3 days, there is no new case. And I will be in Rwanda on the 28th, and that one will be almost 14 days from the last case. And we hope, as you know, the incubation period is the 21 days. If there is no new case, we hope by the 7th of November, the level 3 status will be lifted and everything will be almost normal, because we hope that we will not have a new case, and we'll continue also to hope that we will not have new deaths. Thank you, Minister. I will join you to the Pandemic Fund Board meeting immediately after the press conference. Colleagues, thank you. My apologies to other board members. I will join immediately after the press conference. Let us go back to the presentation that we prepared. We can still answer some questions, some additional questions, because we are working together. But let us move quickly on the Mpox. Next slide, please. On the Mpox, we don't have good news as we expecting, as we got for the Marburg. I'm so sad to say we now have more than 1,000 deaths due to Mpox. As you can see, this week, week 40, we have 1,100 deaths reported in total. And you will see that the new cases, we are still having more new cases week after week. For the week 40, we have 3,051 new cases and 50 deaths recorded. This brings in total 42,000 cases. And you will see in the previous slide, we're presenting 196% of increase, 200% of increase. But if we compare the week 40 in 2023 with the week 40 in 2024, there is 380% of increase. This is huge. Next slide, please. You will see how everything is presented. You will see the update. For the first time, we have cases in Zambia, reported on 8th of October. We have cases in Zimbabwe, and we have additional cases in Uganda, Ghana, but unfortunately, we have the first death in Kenya. We are saying that every day, while we can say that Marburg is controlled, but Mpox is not under control, we are still fighting with this outbreak. And now we have new countries, as you can see in the map, new countries, and we don't want to see all African countries being affected. This is why we need to intensify our effort. Next slide, please. Look how it's moving from January to date. If we compare, we take some period of time. Why are we talking about April 2024? April 2024, it's when AfricaCDC organized this regional meeting in DRC, bringing a number of countries. At that moment, they were at-risk country, and trying to sensitize the world about the need for Africa to have vaccines, to have therapeutics, to have diagnostics. At that moment, we had only 5,967 cases. But in August, when we declared the public health emergency of continental security, we moved from 5,000 to 23,000 cases. Also, we moved from 3,023 deaths to 617 deaths. Today, for the data that we have as of 15th of October, you can see the trend. It's almost the double of the period January-August, because we have 42 cases, 42,000 cases, and 1,100 deaths. You will see we moved from 6 countries now to 18. We are saying +5 if we compare with the August period, but from 6 to 18, we are talking about 12 additional countries in a few period of time. We need to do our best under the Continental Response Plan to accelerate the response. We are calling upon all of our partners, those who pledged resources. This is time for us to disburse and to stop meetings that we have, to start to go in the field to respond to this outbreak. Next slide, please. We wanted to flag 2 issues. The first one is IDP, internal displaced people, and then we'll talk about people who are in prison. Like in DRC, you will see in the eastern part of DRC, we take North Kivu, you have 2.5 million internal displaced people. Let me remind you, 2.5 million is the population of some countries in Africa. And these people are living in a very precarious situation where they don't have access to water and sanitation hygiene. They don't have access to appropriate food. They are facing a number of additional outbreaks, because let us know that while we are fighting Mpox, measles is still there, cholera is still there, malaria is still there. And that one is another bomb. This is why we are giving also priority to vaccinate all of these people who are IDPs. Next slide, please. This one is in Uganda. We got this week 2 new cases coming from prison. And that prison, the Masindi prison, people, they were thinking that it was chickenpox. Then after doing the testing, we found that it was Mpox. And we are saying, even if we have 0 death, but prison, like IDPs in the eastern part of DRC, it's a major challenge for us, because people in prison, they don't have access to what we call the IPC, how to prevent the contamination. And some of them, they don't have sufficient access to wash, hygiene conditions. And we believe that we need also to vaccinate all people who are in prison, because that one can be another source of contamination. Next slide, please. When we talk about vaccination, we wanted to show you where we are with the vaccination plan. Because our plan to ship vaccines to countries is mostly related to the availability of the vaccination plan. If a country doesn't have a vaccination plan, we are not so comfortable to ship vaccines there because we don't know how they will use that. As you know, we have what we call the Technical Review Committee, bringing so many African experts. They are reviewing all vaccination plans to make sure that we are well articulated with the target. And you'll see, currently we have only 4 countries with the vaccination plan. Others, they are working on that. We are following Côte d'Ivoire. We know that South Africa, they worked on that. But we believe once everything is in place, all of these countries, they will receive vaccines. We have good news because our partners from European Union, mostly HERA, they informed us that they have available 365,000 doses of vaccine that can be shipped anytime from next week. And we already made some suggestions, and we are waiting to confirm for some new countries with their vaccination plan before moving forward. And we are also working with Nigeria. They got 10,000 doses from the US. Out of these 10,000 doses, they gave 1,000 to Rwanda. But now they are planning to start the vaccination campaign on the 22nd of October. We hope that it will take place very quickly and we can move on with the vaccination plan as agreed by the TRC. Next slide, please. We are sure that you wanted to know if things are moving well in DRC. We started with these 3 provinces based on the vaccination plan from the provinces, and you have the target, and you can see the coverage to date. We can see that with this coverage, we can agree there is good acceptance of vaccine. And that one even is unlocking DRC authorities to request more vaccines because the campaign will start in additional provinces like Equateur, Sankuru, South Ubangi, and then Kinshasa. As you know, Kinshasa, we have clade 1A and clade 1B together. And if you can see, 2 weeks ago when I made the presentation, I showed to you the impact of resuming school. We saw an increase in terms of cases in Kinshasa. This is why now Kinshasa becomes a priority. We believe, and I will be in Uganda tomorrow to work with the ministry and also to discuss with the president about how we are moving with this agenda. Then immediately after Uganda, Saturday and Sunday, I will be in DRC to evaluate with DRC authorities how the campaign is moving. As I told you, I stopped all trips out of Africa to focus more on what's happening in Africa. This is why I didn't attend the World Health Summit. This is why I will not attend the meeting in Brazil, and I will remain in the continent to be in Rwanda, Burundi, DRC, Uganda, and Tanzania. Next slide, please. Next slide. This one is just to give you on more details about people who benefit from this vaccine. You'll see the first one is contact they represent 41%. They are followed by frontline workers, because we need to protect our health workers, 27%. And then we have others like sex workers, mostly because, you know, the clade 1B is also sexually transmitted to others. And we will continue to provide, you know, the breakdown in terms of vaccination for us to follow the trend and to know exactly what progress we are making. These target groups are the target groups decided by DRC for the vaccination campaign. And we are supporting their leadership and we are supporting their vision on that. What is the issue that we are facing till date? Vaccine for children. As you know, the Bavarian vaccine, we can just provide this vaccine for 12 plus. But we need, knowing the epidemiology, to have vaccine for our children. And for now, we are still waiting for vaccines that will come from Japan that was accepted for use to children. This is the challenge that we are facing for now. And we hope with the discussion that we have with Japan that we can accelerate the shipment of this vaccine in DRC and other countries. Next slide, please. The minister already shared information about Marburg, but wanted also to share with you that a vaccination in Rwanda is moving. They got additional doses, 5,000 doses, and we know there is this context of Marburg, but they will resume the vaccination today for Mpox, and we believe that we can continue to vaccinate more people in Rwanda. Next slide, please. In summary, before giving the opportunity to my colleague Chanel to come, because we want to be accountable, I will come back to that. In summary, this is everything that we shared with you. We still believe that the cross-border transmission is a major issue. We see cases in Zambia, we see cases in Zimbabwe, and other countries already affected. We can still see infection. I think this one is pushing us to reinforce the cross-border surveillance. Unfortunately, to date, we still not have the rapid test. We are close to have rapid tests because our team, led by Dr. Yenyu, and what we call the Diagnostic Advisory Committee, they are working tirelessly to finalize that. I think by in a few days, we'll share with you the good news about the rapid test for the cross-border surveillance. We also discussed this issue of IDPs and prisoners. We say they are target for us for vaccination because their living conditions can also be another opportunity to spread the disease. And we also know that the risk communication and community engagement is critical at this stage to ensure that we are reaching 100% of the target. Because we, when I say we, it means AfricaCDC and all other partners, WHO and all other partners under the IMST, the Incident Management Support Team, we want to be transparent. And we want, at the end of this outbreak, to send one message. How much did we get from member states, from partners, even if it was in-kind donation, to stop this outbreak? For that, I committed to you that we'll have a dashboard. This dashboard is finalized at 90%. My colleague Chanel will lead us and we'll see what is this dashboard, what kind of information we can get there on a daily basis, and how we can continue to support the response. Chanel, over to you, please.
Great, thank you so much, Director General. So colleagues, I'm pleased to share with you a beta version of the dashboard. So it currently is not live. We are consulting with partners on some of the data inputs, but we wanted to give you a preview. We're about a week away from being live. This first page here is the landing page, and this is basically will be the entry point for the dashboards on the different outbreaks. So we have Mpox in development and also Marburg in development, but overall, this will be the entry point for any of the dashboards for which there is a continental response. So when we click in the dashboard, we have 4 different tabs or 4 different areas of focus, starting with the epi situation. So as you can see, this is the data that's uploaded from week 39. We have a few things that haven't generated, but this will be a place to for you to look at the epi situation and the different indicators, and this will continue to be built out, including with test rates by country, etc. And you can see that there's a continental overview and then also country specific data. We also have a section on programmatic response. Currently, the focus is on looking at which member states have an NPRP, so a National Preparedness and Response Plan, and we segmented that by the risk category that's been identified in the Continental Preparedness and Response Plan. So we have 7 of 7 countries in risk category 1 have their NPRPs, and then 13 in risk category 2. For risk category 3 countries, they're supposed to have a contingency plan, and we haven't mapped that yet. And you can also see here there will be a status of that have vaccination plans and who has commenced vaccination. And this will also be built out with different programmatic response indicators. In terms of resource tracking on this tab, we will have here what is in the continental plan in terms of the budgetary needs. So by segments, so whether it's partners or member states, also by pillar, and also by country. So we have the budgetary needs that are in the plan, and then we are also tracking the financial pledges and commitments that have been made. And you can see this will be listed on the right-hand side. Over time, we want to have more information on the specifics of these pledges and commitments. In particular, how do they relate to which pillar, which country, and which partners are being supported, so we can understand whether the resources are available or whether we still have gaps in some of the pillars and some of the countries. We also have under this a tab on donations in kind, and well, I'm not seeing here contributions in kind. So here you can see that in the continental plan, the target was, or the expectation was, that there would be vaccines donated, and you can see to date this is listing the type of vaccine, the donor, and the number of doses. And on the right hand side, of course, partners make other contributions in kind as well, and this is showing some of the technical assistance that's being provided. So this will also be kept current. And the last tab is on partners, and this is a tab that will show the number of partners that are working in each pillar and also in each country on the response. And yeah, maybe just to say, we at the landing page, we're going to invite comments and feedback and questions. So there's a contact email, and as the Director General said, we want to be transparent and also accountable. So we look forward to engaging with you and a broad set of partners to help us give an accurate situation of what is happening on all across these categories. So with that, I thank you, Director General, and pass the floor back to you.
Thank you so much, Chanel. I think, dear colleagues, the main words here are accountability, transparency. we want African countries to contribute. When you get access to this dashboard, you'll see we provide also information of African member states who contributed to this response. We want them to be proud of what they are doing. You will also see we are providing information from all partners who contributed. If the information is not there for some partners, this is why Chanel yesterday sent an email to all partners for them to provide an update. And we want to recognize all of them, and we want to make sure that at the end of this outbreak, it will be the first time immediately after the outbreak when we lift the public health emergency of continental security, we can say how much Africa got from member states, from partners, in-kind donation to stop the outbreak. And we'll build on that as lesson learned for the future. We'll also do the same dashboard for Marburg. As you know, Rwanda is facing Marburg. We are providing a lot of resources to Rwanda. The government is providing a lot of resources. We want to know how much it costs to stop, to reduce the case fatality rate, and what we need to do in the future to shorten the time if we must have another Marburg outbreak. I will stop there. Back to you, Margaret, for questions from our colleagues.
Thank you very much, DG. Let's get the first question from Janice of Bloomberg. You have the floor.
Good afternoon. Thanks again for taking the time. I guess my two questions, both relating to Mpox. One was, you've said that the testing rate is still suboptimal. I think WHO yesterday was saying less than half of suspected cases have been tested. What can be done to change that or improve that? And then the other question was really related to some of the new countries like Zambia and Zimbabwe, where we've seen Mpox case. I was wondering if there's if you're getting any information as to which clade these are. Certainly in Zimbabwe's case, it seems that it probably came from South Africa, which may indicate that it's clade 2B, but you know, until we actually have that information, I wouldn't want to make any assumptions. And I just wondered if you were getting that information, and if not, what was being done to get better clarity on what you were looking at.
Thank you, Janice. Before DG response, let's get one more question from Carmen of Politico. You have the floor.
Thank you so much, Margaret. I just wanted to clarify something. Dr. Maria Van Kerkhove at the World Health Summit on Tuesday said that 26% of the budget for the Continental Response Plan has been covered. So basically, that's how much you have received. And I was a bit confused because I remember a few briefings ago when you were telling us that you had received commitments of at least 800 million. But a 600 million sort of ask. So I wanted to see if there's been any change to that, or if there's, like what's the status of that? Have you received, more than the 600 million commitment? And can you talk a little bit about how much money has actually come in, since you were mentioning earlier, the need to start dispersing? Thank you.
Thank you. Over to you, DG.
Thank you so much. I will answer the second question from Janice and the question from Carmen, and my colleague, Yenu, who is director for lab in AfricaCDC, will answer the first question related to testing rate. Yes, I think as you saw in my presentation, the case from Zambia, based on the report that we received officially from Zambia, was a Tanzanian truck driver. And about Zimbabwe, there is also this history of Tanzanian truck driver, but also South Africa. Currently, we are still doing the genomic sequencing to know if it's clade 1 or clade 2, and if it's clade 1, is it clade 1A or is it clade 1B? I think we'll come back to you with this information. We don't want to share rumors, but for now, we are supporting these two countries to conduct the genomic sequencing and will report back. Regarding the budget, this is my clear message to our partners. We acknowledge their pledge, but we need quickly to translate pledge into concrete money to support the response. We are working together and we see the trend. I have to say it loudly, clearly, that Mpox is going out of control if we don't act. More than 1,000 people recorded as death. We see, if we compare the 3 periods, we started from April to August, 12 more countries. If we need to continue with all of these meetings and discussions, and we don't end that, will not succeed. From what I know, we are still talking regarding some pledges made, including what you said, Carmen. And we hope to finalize all of these discussions next week to translate these pledges into concrete money, concrete tools, concrete vaccines for our countries. Back to Dr. Yenyu, are you connected for the testing rate?
Yes, DG, I'm online.
Yes, please go ahead.
Yeah. So thank you for that question. I think to increase the testing rate, we are implementing a 3-pronged strategy. Number one, we want to increase the throughput of testing in centralized labs by bringing more test kits, training more people, and also supporting sample transportation. And second, we are also supporting some sub-regional labs which have PCR testing facility, so that we decentralize testing to sub-regional level. And then we are also supporting decentralization of testing using near point of care molecular tests like GeneXpert, which is actually available in many facilities. And then the last one was which previously the Director General explained, that if we get quality rapid diagnostic tests, which we are actively searching, so we'll be also deploying those rapid diagnostic tests which are antigen based and which can be done with very limited infrastructural need and can happen in a peripheral site. So that's the type of strategy that we are employing to increase testing strategy. And as DG mentioned, there has been some improvement, but we need to do more to really increase the testing coverage. And our target as part of our expansion of testing strategies to test 80% of all suspected cases, so that we contribute to enhanced surveillance program. Thank you.
Thank you very much. Let's take the next 2 questions. Kerry from Health Policy Watch, you have the floor.
Thank you, Margaret. I have a follow-up question on the testing. Yesterday, Dr. Tedros was suggesting that measles and chickenpox were maybe confounding the suspected cases. And I know, Dr. Kaseya, you've said a similar thing. So I wondered whether you could clarify what are the differences in how those cases present, how Mpox is differently presented to those two. And my second question is related to the DRC vaccination campaign. I see that there targets for reaching the key population, what we would call key populations in HIV, men who have sex with men and sex workers, they're not doing particularly well. And one knows that stigmatized communities need very sensitive approaches. So I wondered whether there was any particular campaign, that messaging, or whether they were working with particular community organizations to reach hard to reach communities. Thank you very much.
Thank you. Let's take the last one before the experts can come in. Esther from Uganda, you have the floor.
Thank you very much, Margaret, and thank you, DG. My question is kind of similar to what Kelly has asked. You have said that we have there's monkeypox in prisons in Uganda. And I wonder, are prisons in the different countries a priority for governments to start testing and giving vaccines to these people? And secondly, prisons are segregated for men and women. Do we know whether this is in female prison or male prisons? And can you please speak about sexual transmission of Mpox in the region? Thank you.
Thank you very much. Over to you, DG.
Thank you so much. My colleagues from IMST and Dr. Yenyu, they will address the first question regarding from Kerry. But let me answer the second one about the DRC vaccination campaign, mostly related to key population, and we are talking about MSM. We are clear as AfricaCDC. We are saying all human beings have the same right. And we are supporting countries to plan vaccination for all of them, including men having sex with other men. We are proud and we are glad to see in DRC figure that we have MSM included. As you said, we need to stop with stigma. What happened with clade 1B? We need to recognize that the first message that we gave to people was wrong. We said clade 1B is only associated to sexual transmission. This is the first one. The second one, coming from the 2022 outbreak, there was the stigma talking about men having sex with other men as the main transmission mode of Mpox. But if we put everything in the context, in Africa, that one in some countries is still a taboo. But we believe with our effort, what we are doing, we are sensitizing countries, and we are proud to see that DRC, they are mentioning that. Yes, we need to continue to intensify what we call risk communication and community engagement, and to use community leaders, to use even those who are openly saying we are these key populations, to sensitize others. I think this is what we are doing, and I'm so proud to say it's the starting point, and we are moving. Regarding the question from Esther, if the prison is a priority for testing and vaccination, I can say all ministers who discussed with me clearly understood that when you have a concentration of people, like in prison, in the context of this kind of outbreak, you must take it seriously. I attended some meetings where it was clearly said prison is an area where we will test and vaccinate. We congratulate Uganda because they did it and they continue to do that. There are a number of contacts. What I got from the Uganda's report, it's mostly men who are infected, and we are talking about 1,087 for inmates with possible contact, and all of them will go through this testing to make sure that we don't have any other case that can become the reason for major outbreak in Uganda. I will hand over to my colleagues from IMST about the first question and the case management. Over to you, Chanel and colleagues in IMST.
All right. Thank you, Your Excellency, DG. Yeah, so in terms of the differences, or rather, how do you determine this could be chickenpox and this is Mpox, a lesion? So I would begin by saying that differentiation could actually to be a little bit difficult, you know, for a person that actually hasn't been trained or seen it. But one of the most important aspects is for Mpox lesions, they're actually bigger compared to the lesions that you see in chickenpox. Then the other aspect is the lesions or sores, that are manifested in Mpox are quite very, very painful compared to chickenpox, which are just basically itchy. So you can be able to differentiate, once a patient is actually, explaining or you actually seeing these symptoms. Then with measles, of course, these are very actually, they're tiny, small rash actually that develops on, and usually it affects mostly children, but they're very small, even compared to chickenpox and monkeypox and chickenpox as well. But that differentiation is actually quite critical. And one of the things that we are doing as AfricaCDC is to ensure that we build this capacity in terms of screening for Mpox patients. So our frontline healthcare workers are being capacitated in terms of how do they identify these Mpox cases. So we actually actively conducting these training and ensuring that we empower our clinicians not to miss a single case. Also for our communities, I think our RCC, our risk communication community engagement as well, are showing actually how Mpox, chickenpox, and measles actually do present. But it's pretty easy actually to differentiate the two once I think we train and orient the communities and as well as our healthcare workers. Thank you, DG, and over.
Thank you so much. Back to you, Margaret.
Thank you, DG. We are out of time currently. I would like to pass it on to you for closing remarks.
Thank you so much, colleagues, for joining us today. We want to sincerely thank the Minister of Rwanda, who, despite the fact that he's the chair of the board, but he managed to find time to be with us and to provide the update. We are moving with Marburg. As I said, what are key messages? First, zero new case for the past 3 days. And we hope to lift the L3 status after 21 days. It means we are targeting 7th of November. And I will be in Rwanda on the 28th to see the progress we are making. We are crossing our fingers with the leadership of the government of Rwanda, the support from AfricaCDC, WHO, UNICEF, and all other partners. We can achieve 0 death and 0 new case. We are also glad to say the partnership that AfricaCDC has with Gilead to provide medicines to Rwanda to cure Marburg is working. And that one is one of the major lessons for the future. And we'll continue to see how we can make this medicine available for all Marburg diseases. In terms of Mpox, we said we are not making huge progress. And we are, unfortunately, we recorded the first 1,000 deaths. We believe we will not record more than that in the future. This is why our message, I will also attend immediately after this press conference, the Pandemic Fund meeting, to push our partners. Pandemic Fund gave us $129 million to release this fund very quickly. We'll continue to talk to the US government to release the $500 million very quickly. We'll talk to other partners. We want now to see concrete action on the ground to stop this outbreak. 18 countries is too much. We cannot continue like that. We need to save life of people. We need to give future to our continent. We believe next time when we'll meet, to give you some good news, some progress we are making, and we thank you for supporting this agenda. That is a major one for our continent. Thank you so much, and we'll meet on Thursday next week.